And maybe with that, maybe we move
Yeah.
on to the final abstract, which Omar will
Yes,
discuss.
yes, and just wanted to follow up small, as a limitation because,
Yeah.
in order being fair to
Yeah.
the UNITE database, while it's, a large effort from
Yeah.
16 multiple centers, we have to preface that the histologies were not centrally reviewed, so that will always be,
Yeah.
a limitation. I just wanted to kind of bring this up.
Yeah.
Now, for our abstract, we actually looked at a question that we thought is relevant to the field. As more and more therapies get into the bladder space, including erdafitinib as a targeted therapy, we actually looked at the patients within the UNITE database that had next generation sequencing. So out of the close to 600 patients that are within the UNITE database, 450 and some change had next generation sequencing data contributed from multiple centers that contribute to the database. And within those, we focus on the patients that harbor FGFR2 or 3 alterations. And those were 93 patients. A large number of patients that are, it's hard to get to that number and study the sequence of therapies outside of such collaborative effort. And within those 93 patients, we tried to see, when it comes to the question, these patients have progressed on immunotherapy for the most part. In these 93 patients, more than 90% of them had prior immunotherapy. 60% of them had prior platinum. And then the question was at the third line therapy, how did their outcomes differ based on the line of the treatment that they received? Some of them received enfortumab vedotin, followed by erdafitinib when they progressed. Some of them received erdafitinib, followed by enfortumab vedotin, and there are some that only received enfortumab vedotin and did not receive erdafitinib. The numbers are for the group that received erdafitinib first, then enfortumab vedotin. Those were 23 patients. We had 15 patients that received enfortumab vedotin followed by erdafitinib, and then we had 55 patients that received enfortumab alone. I have to state a limitation also that we don't have a fourth group, which is the group that got erdafitinib and couldn't get enfortumab vedotin. That's, a control group that does not fit per se the definition of the UNITE database, but it would be important to kind of get to those patients.
Yeah, and of course the length of follow-up I think also affects things because some of the patients who received enfortumab alone probably eventually will receive erdafitinib.
Correct. That's also another important method, caveat. So within the results, we looked at our primary, sort of endpoint was to look at the overall survival of these patients because it's hard to focus on response when it's not really centrally reviewed in this database. But overall survival tends to be a solid finding. And so what we found is in the patients that received enfortumab vedotin followed by erdafitinib, the median OS was 19 months. The other way around, that was enfortumab followed by erdafitinib was 21 months.
And that's from
the initial therapy for this sort of third line space. And then the third group was enfortumab alone, and those had a median OS of 12 months. And we did, a multivariable analysis trying to adjust for variants that we think or variables that we think can contribute to survival. So we factored in the sequence, whether it was enfortumab followed by erdafitinib or the other way around, versus if the patients had visceral mets or if they had low performance status or if they had low BMI. And really in the multivariable analysis, the factor that was the most important was as long as the patients get the sequential therapy, they were able to sequence the treatments. That's what ended up factoring the most in terms of their overall survival. Now we did look at responses to enfortumab and also responses to erdafitinib, and they are comparable. And we looked also at progression-free survival. And in the three different groups, whether it was sequence of erda followed by enfortumab or the other way around or single agent, the median progression-free survival on enfortumab was around 5 months. We don't have the data for progression-free survival on erda, and that's a limitation.
Yeah, and my overall takeaway from this, and let me know if you agree, is that for patients with FGFR3 alterations who are eligible for both erdafitinib and enfortumab, it's important to get them on both treatments in whatever sequence, right? And as long as we do that, those patients actually have pretty reasonable long-term outcomes.
Yeah, I think it just reinforces what what we all do, which is molecular sequencing remains very important.
Yeah.
And so understanding kind of the landscape and trying to get that early on in a patient's metastatic course can be very helpful in terms of figuring out a trajectory of treatment options.